Hi, welcome to the live session for a last minute revision of OBS. Now today the topic which I have chosen to explain to you is Partogram and CTG. I have chosen this topic because one, this topic is very difficult. For so many times students ask me questions regarding Partogram and CTG. And number two, this topic is very important for all exams, whether it is NEET, whether it is AIMS, whether it is JIPMER, whether it is the FMG exam. At least one question on Partogram and one question on CTG is definitely going to be there in your papers, right? So let's begin our discussion about Partogram first. Now, before I tell you how a Partogram is made and how you have to interpret a Partogram, what is important is that you should know the definitions of normal labor and abnormal labor. These definitions have also gone drastic change in the past few years, right? So let's begin what is normal and what is abnormal labor. Now, all of us know that labor has 4 stages. I want you to draw this table with me. First stage, second stage. So all those students who've attended my classes, they've already drawn this table. Third stage and fourth stage, right? Now, first stage of labor, how do you define first stage of labor? It is from when it begins, when the true labor pain begins, and it ends with the full dilatation of the cervix, which is 10 centimeters, right? Now, second stage of labor will begin with full dilatation of the cervix and it will end with the delivery of the baby, right? Third stage, all of us know, it's basically concerned with the delivery of the placenta. And fourth stage is 1 hour observation period following the delivery of the placenta, right? Now, the first stage of labor, it is further divided into 2 phases. So you continue your table. I'm going to the next slide. Right? So the first stage of labor has 2 phases. There is a latent phase and we have the active phase. Now, it's very important to understand that the definitions for latent phase and for the active phase have changed recently. Latent phase, now it is taken when the true labor pains begin and till the cervix is 5 centimeters dilated. Till that time, we say it is latent phase, right? And active phase is when the cervix is more than equal to 6 centimeters dilated and up till it is fully dilated, right? Earlier, it was said that active phase begins at 4 centimeters dilatation. Now, 6 centimeters is the new 4 centimeters now. Now, active phase begins at 6 centimeters dilated. It doesn't begin at 4 centimeters dilatation. These are the new definitions, right? Now, what is the normal duration of each of these stages and phases? Normal duration. So, I am again taking it on the next slide. You continue your table there. The normal duration in a nulliparous female. What do you understand by a nulliparous female? A female who's never given birth, that is a nulliparous female, and in a multiparous female, right? So in the first stage, we are talking about the normal duration of latent phase. The normal duration of latent phase in a nulliparous female is 12 hours and in a multiparous female it is 8 hours, right? Normal duration of the second stage of labor in a nulliparous female is 1 hour and in a multiparous female it is 30 minutes. third stage. Now, the duration of third stage of labor, it doesn't depend upon whether the patient was a nulliparous female or whether she was multiparous. The duration of third stage, it depends upon whether you have actively managed the third stage or whether you have passively managed the third stage. Now, active management of third stage of labor is very, very important. I'm not going to tell you details here. If you want to know more details about the active management of third stage of labor, you can watch my videos of OBS and Gynae with marrow, which will soon be available, right? Now, if you have managed the third stage of labor passively, then the duration of the third stage of labor is 15 to 20 minutes. And if you go for active management, which is the one which is preferred, then the duration is reduced to 5 to 10 minutes, right? Now, fourth stage of labor, as I told you, it is 1 hour observation period following the delivery of the placenta. So, the duration of the fourth stage is 1 hour, right? So now let's know about the prolonged stages. When do you say that the latent phase is prolonged? You say the latent phase is prolonged if in a nulliparous female it is 20 hours, more than equal to 20 hours, or in a multiparous female it is more than equal to 14 hours, right? Second stage is said to be prolonged if it is more than equal to 2 hours in a nulliparous female or it is more than equal to 1 hour in a multiparous female. Now, all this is without epidural, right? Suppose for pain relief, you had given epidural to the patient. In that case, you have to add 1 hour each, right? So, with epidural, the prolonged second stage would become 3 hours or more in a nulliparous female and 2 hours or more in a multiparous female. Third stage is said to be prolonged if it is more than equal to 30 minutes. That means after the delivery of the baby, 30 minutes have passed and the placenta has not yet delivered. So whether you call it as the prolonged third stage of labor or whether you call it as retained placenta, the definition or the time duration is the same, right? And they can nothing be like a prolonged fourth stage. Clear? Now, let me tell you a little bit details about how to manage these, right? So, what will be the abnormal labor, right? In abnormal labor, first we are going to talk about abnormalities of the first stage of labor. In the first stage of labor, first we are talking about latent phase, right? So the first problem which can happen is that the latent phase can be prolonged. Prolonged latent phase. Right? Now, latent phase, as I told you, you are going to call it as prolonged if it is more than equal to 20 hours in a nulliparous female or it is more than equal to 14 hours in a multiparous female. Now, what can be the causes of prolonged latent phase? See, the causes of prolonged latent phase could be that the cervix was not ripe, right? The cervix was very thick, it was uneffaced cervix and you induced labor, right? So, if it was a thick, unripe cervix, that can be one reason for prolonged latent phase, number one. Number two, if you have given excessive sedation to the patient. Right? Now, if I have given excessive sedation, I know that I have given excessive sedation. If the cervix is unripe, I will do a per-vaginal examination and I'll come to know that the cervix is unripe, right? The drug of choice for ripening of the cervix is dinoprost, right? Now, the third and the most important cause for a prolonged latent phase is Actually the patient was not having true labor pains. Patient was having false labor pains, right? So patient is not in true labor, right? Now, there are many differences between true labor pains and false labor pains. Again, for those differences, I would want you to watch my videos which are available with Marrow. But one very important difference between true labor pain and false labor pain is that false labor pains will subside if you give rest to the patient, right? Whereas true labor pains, they do not subside. Once they begin, right? You cannot make true labor pains subside, right? So in case the patient is not in true labor and you are suspecting that the patient is in false labor, what you do is, the management is, you give therapeutic rest to the patient. The advantage of giving therapeutic rest is that if patient will be having false labor pains, right, they will subside. And by chance patient is having true labor pains and actually it is a prolonged latent phase, then by the time patient wakes up, she will automatically be in active phase, right? So the best management for a prolonged latent phase is therapeutic rest. Clear? Now, this is abnormality of the latent phase. Let's talk about active phase. In active phase, there can be two problems. One problem could be that the active phase could go slow, right? So that is called as a protracted active phase. Protracted active phase. Now, when I say active phase is going slow, then you should know what is the normal duration of active phase. Then only you will come to know whether it is going slow or not. So normally, in active phase, two things are happening. Number one, there is dilatation of the cervix. There are two actions which happen in active phase. Dilatation of the cervix and descent of fetal head. Right? Normal dilatation of the cervix in a nulliparous female is 1.2 centimeters per hour. Right? Whereas in a multiparous female, it is 1.5 centimeters per hour. That is the normal dilatation of the cervix in a nulliparous female and in a multiparous female. Descent of fetal head in a nulliparous female is 1 centimeter per hour and in a multiparous female it is 2 centimeters per hour. Now if active phase is going slower than this, then you call it as protracted active phase. If it is slow than this, then you are going to say it is protracted active phase. Right? So either the dilatation is going slow or the descent of the fetal head is going slower than the normal. That is called as a protracted active phase. Now, one very important question here is that according to WHO, minimum dilatation should be 1 centimeter per hour. Right? So WHO says that forget about nulliparous, forget about multiparous. It says that the minimum dilatation in active phase should be 1 centimeter per hour. Right? So this is protracted active phase. Now, common sense tells me that if active phase is going slow, right? Now, how do you manage a protracted active phase? Now, whenever active phase is going slow, first thing what you have to do is you have to check whether there is CPD or not, because one very important reason for a protracted active phase could be cephalopelvic disproportion. So the first thing is you should rule out CPD. Just in case there is cephalopelvic disproportion, obviously you will have to go for cesarean section. Number 2, you will have to rule out occipito-posterior position. Now, if head of the fetus is in occipito-posterior position, head has to turn and it has to become occipito-anterior, right? And then only it is going to deliver. Now, if from occipito-posterior, it has to turn and it has to become occipito-anterior, it has to undergo a very long turn, right? And that is going to take some time, right? So, if you do a per-vaginal examination and you come to know that it is occipito-posterior position and that is why the active phase is getting prolonged, in that case, you have to do nothing. You have to just wait and watch. And this question has been asked so many times in all exams, that during labor, if you come to know that the head of the fetus is in occipito-posterior position, what is the management? Simply the management is wait and watch. Automatically, the head of the fetus will become occipito-anterior and normal delivery will happen. Now, once you have ruled out that there is no CPD, there is no occipito-posterior position, and still the active phase is getting prolonged, then the management is you should accelerate the process of labor. In other words, you should augment labor. And there are 2 methods for augmenting labor. Number 1, artificial rupture of membranes. Now, why is it that artificial rupture of membranes augments labor? That is because when you rupture the membranes, prostaglandins are released, PGE2 is released, right? And that augments labor. Number 2, oxytocin. So, the management of protracted active phase is that you have to augment the labor by doing artificial rupture of membranes or by giving oxytocin. Now, a second problem in the active phase of labor could be active phase arrest. Active phase arrest. Now, what do you mean by active phase arrest? Active phase arrest means that 4 hours have passed. Now, again, very important, this has changed. Earlier, they used to say that active phase arrest means when there is no dilatation at all and 2 hours have passed. But now they say that 4 hours have passed and still there is no dilatation of the cervix. What do I mean by that? Suppose a patient was admitted to you at 10 o'clock in the morning, right? When you did 10 o'clock in the morning, when you did a per-vaginal examination, her cervix was 6 centimeters dilated. That means this patient was in active phase, right? And you went for your OPD, you had to do a cesarean, you went to do a cesarean. Now, once you come back after 4 hours, that is around 2 o'clock, you ask your intern that what is the dilatation, and she says, ma'am, still it is 6 centimeters dilated. Now, if the patient remains at the same dilatation, that means there is no dilatation and 4 hours have passed, then you call it as active phase arrest. But then there is a catch here. Active phase arrest is a big diagnosis to make, right? Because now the only management left for you is cesarean section if it is actually active phase arrest. So before you make the diagnosis of active phase arrest, there are 2 prerequisites. Number 1, uterine contractions should be adequate. Right? Unless and until contractions are not adequate, till that time you are not going to make the diagnosis of arrest. By chance contractions are not adequate, then before you make the diagnosis of arrest, you should increase the strength of uterine contractions by giving oxytocin. Right? Number 2, membranes should be ruptured. So you cannot make the diagnosis of arrest unless and until these two conditions are fulfilled. Suppose you at 2 o'clock when you went and you saw that patient, actually the dilatation was 6 centimeters, but when you put your hand on her uterus, you find out that no, the contractions are not adequate. Now you're going to ask me, what is adequate contractions, right? Adequate contractions means that they have to be 3 contractions in 10 minutes, right? Each contraction should last for more than equal to 45 seconds, and the intrauterine pressure during the contractions should be 65 to 75 millimeters of mercury, right? In other words, approximately 220 Montevideo units, right? So that is how you define adequate uterine contractions. 3 contractions in 10 minutes, each contraction lasting for at least 45 seconds, and the intrauterine pressure during the contraction being 65 to 75 millimeters of mercury. If contractions are not adequate, you are going to start oxytocin, right? So if I started oxytocin after 4 hours at 2 o'clock, again now I am going to wait for 2 hours. So in total, I am waiting for 6 hours, right? I am repeating. Contractions are adequate. Then you say that the arrest of active phase is when 4 hours have passed. Contractions are not adequate and you started oxytocin. Then the diagnosis of arrest is made after 6 hours have passed and still the patient has not dilated. Clear? And another very important prerequisite is that the membranes should be ruptured. Unless and until membranes are ruptured, you are not going to make a diagnosis of arrest. Clear to you? Now, so that it becomes a little more clear, I'll just discuss 1 or 2 important questions. So see here, I've written it here again. Active phase arrest is where the cervix is more than equal to 6 centimeters dilated with membranes ruptured and adequate uterine contractions are present and there is no dilatation for 4 hours. If adequate uterine contractions are not present, oxytocin is given and still there is no dilatation for 6 hours. Then you call it as active phase arrest. So look at this question here. A G2P1 is admitted in labor at 8 a.m. on Monday. Right? Her pervaginal findings are that the cervix is 2 centimeters dilated. That means she is in latent phase. Cervix is 20% effaced. At 10 p.m. Right? Her cervix is 3 centimeters dilated, 80% effaced, fetal heart rate regular, membranes intact. What is the next step in management? Now, first thing first, this patient is a G2P1 female. That means she is a multiparous female, right? And she is in latent phase. At 8 a.m., her finding was 2 centimeters. At 10 p.m., she's still in latent phase because her finding is 3 centimeters. Now, how many hours have passed? 14 hours. 14 hours have passed and still the patient is in latent phase and she is a multiparous female. That means your diagnosis is prolonged latent phase. And how do you manage prolonged latent phase? Therapeutic rest. So what is the next step? Therapeutic rest. Right? Now look at this question. You are following a 38-year-old G2P1 at 39 weeks in labor. She has had one prior vaginal delivery of 3,800 grams infant, right? 1 week ago, the estimated fetal weight was 3,200 grams by ultrasound. So this time, the weight of the fetus is less than what the weight of the fetus was last time. Over the past 3 hours, her cervical dilatation has remained unchanged, right? And that is she is 6 centimeters dilated and just now also she is 6 centimeters dilated. Fetal heart rate tracing is reactive. An intrauterine pressure catheter reveals 2 contractions in 10 minutes with amplitude of 40 millimeters each. Which of the following is the management of this patient? Now see, in this case, we are seeing that this patient is in active phase and she is 6 centimeters dilated for the past 3 hours, right? That means her active phase is going very slowly. I cannot call it a rest just now, right? But yes, her active phase is going very, very slowly. Now, one very important reason for a protracted active phase, as I told you, is that it is CPD. Now, this patient cannot have a CPD. Why? Because earlier she has delivered a baby of 3800 grams. This time it is 3200 grams, right? Now, before I go to the next step, that is before I wait, before 1 hour passes and I now call it as a case of arrest, what should I look? I should look at the strength of the uterine contractions. In this case, the patient is having 2 contractions in 10 minutes, right? And the amplitude of the contraction is 40 millimeters each, which means that the contractions are not adequate. Now, if the contractions are not adequate, what is the management? I have to give oxytocin. So, my answer here is I have to administer oxytocin. Clear? Now, in this case, I want to tell you that earlier they used to say that active phase arrest is when the duration, when the patient is in the same dilatation for 2 hours. But now they say it is for 4 hours. Now, even if the time when this question was asked, even if that time the arrest definition was 2 hours, still I would have marked administration of oxytocin as the answer. That is because you cannot make a diagnosis of arrest unless and until contractions are adequate and unless and until the membranes are ruptured, right? So whether you take the definition of arrest as 2 hours, like it was taken earlier, or whether you take it as 4 hours like it's taken nowadays, the answer remains the same, that you have to give oxytocin. Clear? See this question. A 25-year-old G3P2 at 39 weeks is admitted in labor at 5 centimeters dilatation. Fetal heart rate tracing is reactive. 2 hours later, she is re-examined, right? And cervix is unchanged and it is still 5 centimeters dilated, right? Now, earlier also it was 5 centimeters 2 hours back, and again 2 hours have passed and still she is 5 centimeters dilated. Now, this is one of the previous questions, right? If this question would be asked now, instead of 5 centimeters, now it will be 6 centimeters. This question was asked long time back when the active phase began at 4 centimeters, right? Now, for your purposes, change this 5 centimeters into 6 centimeters to get the right answer, right? So, suppose this patient was admitted to you at 6 centimeters dilatation. Fetal heart rate tracing is reactive. 2 hours later, she is re-examined and her cervix is unchanged and still it is 6 centimeters dilated. So, how many hours have passed? 4 hours have passed and still the dilatation is 6 centimeters. An IUPC, that is intrauterine pressure catheter, is placed and the patient is noted to have 280 Montevideo units by IUPC. That means the contractions are adequate. After an additional 2 hours have passed, the patient is still noted to be 5 centimeters dilated, right? So already 4 hours have passed and the patient is at the same dilatation in spite of good uterine contractions. What will your next step be? Which of the following will be the best step in the management of this labor? So now it's very easy. What is your diagnosis? Your diagnosis is active phase arrest, right? So what will your diagnosis, your management be? Your management will be perform a cesarean section. Clear to all of you? Again, I am repeating. Earlier active phase was till 4 centimeters and that is why in this question it is 5 centimeters what they have mentioned. If this question will be asked now, it will be with 6 centimeters. And active phase arrest means that there is no dilatation of the cervix and 4 hours have passed in spite of good uterine contractions and after the membranes of the patient are ruptured. Clear? And always the management in such a case is cesarean section. So that was abnormalities of first stage of labor. Coming to the second stage of labor, I am not dealing in detail with the second stage because I have to tell you about partogram. And in order to know about partogram, first stage abnormalities were very important. In second stage, it could be prolonged second stage or it could be second stage arrest. In a nulliparous female, second stage is said to be prolonged if it is more than 2 hours, and in a multiparous if it is 1 hour. Second stage arrest is if in a nulliparous female it is 3 hours or in a multiparous female it is 2 hours. All these definitions are without the use of epidural. If you have given epidural to the patient, you will have to add 1 hour each. Right? Management of prolonged second stage of labor is, see, prolonged second stage means that the cervix is fully dilated and still the labor is getting prolonged, right? In that case, you have one option and that option is you can apply forceps or you can apply vacuum. But these days you apply forceps or you apply vacuum only when the station of fetal head is +2 or below that, right? So whenever you get prolonged second stage, you should look at the station of fetal head. If station of fetal head is more than equal to +2, that means it is at +2 station or below that. In that case, you are going to use forceps or vacuum to deliver the baby. If the station of fetal head is less than +2, in other words, it is above +2. Right? Less than +2 means +1, 0. Then if it is above +2, in that case, you cannot apply forceps or vacuum and in that case, you will have to do cesarean section. Right? Management of second stage arrest always and always is cesarean section. So these are abnormalities of the second stage of labor. Now, with this background, I have to tell you partogram. So, let's talk about partogram, the main topic for today. In partogram, the first type of partogram which was given was by Freedman. Right, so it was a Freedman curve. That was the first partogram which was given. Now, this Freedman curve, it is based on two principles. Number one, when Freedman curve was given, at that time, active phase began at 3 centimeters dilatation, right? And number two, latent phase was said to be prolonged if it was more than equal to 8 hours, right? So on this principle came the Freedman curve. Now, let's draw a Freedman curve. On y-axis, you will have dilatation of cervix. On x-axis, you will have time in hours, right? So the two principles I told you were that active phase is going to begin when the dilatation of the cervix is 3 centimeters and above, and latent phase is said to be prolonged if it is more than 8 hours, right? Now look here, 2 hours, 4 hours, 6 hours, 8 hours, 10, 12, 14, 16, 18 and so on. On y-axis, we have dilatation. right? Now, Freedman said that latent phase will be prolonged if it is more than 8 hours, right? So from 8 hours, draw a dotted line up. And he said that active phase begins at 3 centimeters. So, right? Now, this over here is your line representing latent phase, right? And latent phase is said to be prolonged if it is more than 8 hours. So I have drawn a dotted line from 8 hours. And he said that active phase will begin at 3 centimeters. So I have drawn a dotted line at 3 centimeters. And then I have made a curve which is going up till the place where the two lines are crossing each other, right? This pink colored line is representing your latent phase. Now, from 10 hours, draw a dotted line. From 12 hours, you have to draw a dotted line, and from 14 hours, you will have to draw a dotted line. He divided active phase into 3 phases. Right? This is the first phase of the active phase, this is the second phase of the active phase, and this is the third phase of the active phase. This was latent phase. The first phase is called as the phase of acceleration. Second phase is called as phase of maximum slope. So maximum dilatation has occurred in the second phase. And the third one is called as phase of deceleration. Right? So in Freedman curve, the active phase was further divided into 3 phases. As you can see, Freedman curve is a sigmoid shaped curve, right? But this Freedman curve is no longer used. I'll show you an actual Freedman curve. Can you see here? This over here somewhere will be 3 centimeters. Right? So the curve is coming, the latent phase, and then we have the active phase. In active phase, there is acceleration phase, phase of maximum slope, and the deceleration phase. Clear? But Freedman curve is no longer used. Now, the second partogram was given by Philpott and Castle. The second partogram that was given by Philpott and Castle. And it was Philpott and Castle who gave the concept of alert line and action line. That is all what you have to remember. That it was Philpott and Castle who gave the concept about alert line and action line. Right? Then comes the third partogram. This third partogram is composite WHO partogram. Right? Now this composite WHO partogram is very important, not only for the PGs but for all the FMG students also. This is a very, very important partogram. Now this partogram, it was given as an initiative of the Safe Motherhood program. So as an initiative in the Safe Motherhood program, this partogram came, that was WHO's composite partogram. This WHO composite partogram is based on these following 4 principles. The principles are, number 1, latent phase is said to be prolonged if it is more than equal to 8 hours, number 1. Number 2, active phase begins at 3 centimeters dilatation. That is number 2. Number 3, minimum dilatation in active phase, according to WHO, it should be 1 centimeter per hour. And number 4, the time duration between alert line and action line is 4 hours, right? So based on these 4 principles, now we are going to draw the WHO's composite partogram. Clear? Now, very, very important, you should know how to draw this partogram. Again, on y-axis, we are going to take dilatation of the cervix, and on x-axis, we are going to take time in hours, right? So, time, just go and draw up till, beginning from 1 hour, go up till 22-24 hours. You will have to draw it along with me, otherwise you will not understand. Right? Dilatation of the cervix, 10 centimeters. Right? Now, what did WHO say? WHO said that latent phase is said to be prolonged if it is more than 8 hours. And it also said that active phase begins at 3 centimeters. In other words, latent phase is going to end just before 3 centimeters. Right? So, I am drawing a line, a dotted line. First, draw a dotted line. From 3 centimeters, right? And draw a dotted line from 8 hours. Like this. So, I have drawn a dotted line from 3 centimeters and I have drawn another dotted line going up from 8 hours. Now, this line, this blue line which I have drawn, this will represent your latent phase, right? Now, WHO said that active phase begins at 3 centimeters, right? And it also said that the minimum rate of dilatation in the active phase is 1 centimeter per hour. So, from 3 centimeters, now this patient has to dilate up till 10 centimeters, which means she has to dilate 7 more centimeters. 7 more centimeters means that the maximum time which she can take now is 7 more hours, right? So, 8 hours plus 7 hours makes it 15 hours. So, I am going to draw a dotted line from 15 hours. Have you understood? From 3 centimeters, the patient has to dilate up till 10 centimeters, right? That means 7 centimeters of dilatation, and WHO is saying that minimum it has to be 1 centimeter per hour. That means this patient can take maximum 7 hours to dilate. Now already we are standing at 8 hours, right? So 8 hours plus 7 hours makes it 15 hours. So I am drawing a dotted line up from 15 hours. And I am drawing a dotted line from 10 centimeters. Where both these lines are crossing, I am marking it with X. Both these lines where they meet, you mark it with X, right? Now, this line of latent phase, here also I have marked an X, right? Now, join both these two. Join these two pink X's with a straight line. This becomes your alert line. Right? So have you understood how to draw the alert line? Now, WHO said that the difference between alert line and action line is 4 hours. That means action line is going to begin 4 hours after the beginning of alert line. Alert line is beginning at 8 hours. This is where the alert line is beginning. So 4 hours after that means 1, 2, 3, 4. That is 12 hours. So I am going to draw a dotted line from 12 hours and from 3 centimeters. I'll mark it with an X. Have you understood? That difference between alert and action line has to be 4 hours. So the beginning of action line will be 4 hours from the beginning of alert line, right? And the beginning of alert line is at 8 hours. So the beginning of action line will be at 12 hours, right? And obviously active phase begins at 3 centimeters. So I'm taking it from 3 centimeters. Where the 3 centimeter line and the 12-hour line is meeting, I'm marking it with X. Similarly, the ending of action line will be 4 hours away from the ending of alert line. Now, alert line is ending at 15 hours. So 4 hours away from it. 1 hour, 2 hours, 3 hours, 4 hours. That makes it 19 hours. So I am going to draw a dotted line up from 19 hours. Right? And I am going to draw from 10 centimeters another line. Where both these lines are crossing, I'll mark it with an X. So now I have 2 green X's which I have made. Connect both of them. Join both of them with a straight line. This becomes your action line. Alert line and action line, and the time interval between them is 4 hours. Right? Now this is how you draw a composite WHO partograph. Right? This is because in exams there are certain questions which are asked where you will have to draw it quickly and you will have to plot. But actually when you are conducting labor, in the labor room, this partogram will already be provided to you. See here. This is WHO's composite partograph. See, look here. This from 3 centimeters is the latent phase line, and where it is going up till 8 hours. Right? Then your alert line is beginning. Alert line is going up till how many hours? 15 hours. Right? This over here is your action line, which is beginning from 12 hours and it is ending at 19 hours. This is what you've drawn. But actually this partogram will be provided to you. And what you will have to do in the labor room is, you will have to plot the progress of your patient. Right? So, as long as the progress of your patient, which you will be plotting on this partogram, till the time it remains towards the left of alert line, right here, anywhere here the progress of your patient is coming, till that time labor is said to be progressing normally. So I want all of you to write that. Till the time the progress of the patient is towards the left of alert line, labor is said to be progressing normally. Right? When the progress of the patient touches the alert line or it lies towards the right of alert line. So if it is touching the alert line or if it is lying towards the right of alert line, that means now the obstetrician should get alerted that something wrong is happening. Right? And by chance you are sitting in a very primitive setup. This is the place when you should refer the patient to a higher center, right? This is the time when you are going to refer the patient to a higher center if the progress of your patient touches the alert line or if it comes towards the right of alert line. Now, the moment the progress of your patient touches action line, That means that now you have to take an action, right? And what action you have to take, that depends upon the diagnosis. For example, like I told you, if your diagnosis is prolonged latent phase, your action is therapeutic rest. If your diagnosis is protracted active phase, then your action is augmenting labor with artificial rupture of membranes or by oxytocin. If your diagnosis is arrest of the active phase, then your action is cesarean section. So action does not always mean cesarean section. That is one thumb rule which you have to remember. Always any problem during labor does not mean that you have to do cesarean section. You have to first make a diagnosis, and depending upon the diagnosis, you have to take the action. Clear? One more thing which I want you to note here. In this partogram, as you can see, not only it is telling you about the progress of labor, you are also plotting many other things. For example, you are noting the pulse and BP of the patient. You are noting how many contractions the patient is having in 10 minutes. You are noting how much oxytocin you are giving to the patient. You are plotting the fetal heart rate of the patient. So this partogram will tell you everything what you are doing. Even when the membranes rupture, you write it on the partogram, right? Now, so then they ask you that at what time intervals are you going to plot the various parameters? Now, before I tell you, and that's a very important question, at what time are you going to plot BP, at how much time interval, at how much time interval you are going to plot the pulse, at how much time interval you are going to plot fetal heart rate. Before that, I want you to see something here. This over here is time in hours, 1 hour, 2 hour, 3 hour, 4 hour, right? And this is a big box. So each big box on a partogram is representing 1 hour, right? But below that big box, do you see two small boxes? Right? So the small boxes on a partogram are representing how many hours? Half an hour. That is 30 minutes. Big box is 1 hour. Small box, it is 30 minutes. Right? Now, note down the parameters which you have to note in a partogram. Right? Number one, you have to note down the temperature of the patient. Temperature of the patient, it should be monitored every 4 hourly and it should be mentioned every 4 hourly. Pulse every 30 minutes. Blood pressure again after every 4 hours. But if the patient is a PIH patient, in that case you have to mention blood pressure after every 1 hour. Fetal heart rate, you have to write the fetal heart rate after every 30 minutes. But that doesn't mean that you are going to auscultate fetal heart rate after every 30 minutes. On a partogram, it will be written after every 30 minutes. But auscultation of fetal heart rate, that's very important. At what time interval do you auscultate the fetal heart rate? In the first stage of labor, in the second stage of labor, in a low risk patient, and in a high risk patient. In the first stage of labor, in a low risk patient, fetal heart rate is auscultated after every 30 minutes, and in a high risk patient after every 15 minutes. In the second stage of labor, fetal heart rate is auscultated after every 15 minutes in a low risk patient and after every 5 minutes in a high risk patient, right? So on a partogram, you are going to note it after every 30 minutes, but that doesn't mean that you are going to auscultate it after every 30 minutes. These are the guidelines for auscultating fetal heart rate during labor. Clear? Then, contractions and time interval. Again, I told you each small square is 30 minutes and contractions again have to be noted after every 30 minutes. So by and large, the contractions, the pulse rate, then the fetal heart rate, all of them are written after every 30 minutes. But temperature and BP, they are written after every 4 hours. Clear? This was WHO's composite partogram. Now there is a new partogram which is modified WHO partogram. So let's draw a modified WHO partogram. In modified WHO partogram, there are two differences from the composite partogram. Number one, in modified WHO partogram, latent phase is absent. So it's not represented, right? Number two, active phase begins at 4 centimeters dilatation. Clear? These are two differences between modified WHO partogram and composite partogram. Modified WHO partogram is very important for PG entrants, but it's not important for FMGE students. FMGE students should stick themselves to the composite WHO partogram. Now let's draw a modified WHO partogram. Again, on x-axis, there will be time in hours. So draw up till 14 hours. On y-axis, dilatation of the cervix, right? Clear? Now, in modified WHO partogram, there is no latent phase. So we have to begin with active phase. And when is active phase beginning? Active phase, according to the modified WHO partogram, it begins at 4 centimeters. So at 4 centimeters, I am drawing a cross, right? Now from 4 centimeters, the patient has to dilate up till 10 centimeters, right? That means 6 centimeters dilatation has to happen. And according to WHO, the minimum rate of cervical dilatation is 1 centimeter per hour. That means maximum it can take 6 hours. From 4 to 10, 6 hours. So from 6 hours, I am drawing a dotted line above. And from 10 centimeters, I have drawn another dotted line. Where both these lines are meeting, I am drawing an X, right? Now I am going to join both these X's. This becomes your alert line, right? Now the same thing, the time difference between alert line and action line is 4 hours. So the beginning of your action line will be 4 hours away from the beginning of your alert line. Your alert line was beginning at the time of admission, 0 hours, right? So 1 hour, 2 hours, 3 hours, 4 hours. So from here, my action line will begin, right? Where these two lines are meeting, I am marking it with an X. Clear? Now, same thing, my alert line is going to end 4 hours away from the action line, and my action line was ending at 6 hours. So 4 hours away from it, 1 hour, 2 hours, 3 hours, 4 hours. I am going to make a dotted line from 10 hours up and from 10 centimeters also, right? And where both these are meeting, I am marking it with an X. Now these two pink X's which I have drawn, I am going to join them with a straight line. This becomes your action line, right? So this is how a modified WHO partogram begins. In modified WHO partogram, the initial point of starting or marking is at 4 centimeters because here the latent phase is absent and the active phase is beginning at 4 centimeters. Clear? So now have a look. See, this is modified WHO partogram, beginning at 4 centimeters. This is coming down to, so here the R's are not written, I'll just write it. 1, 2, 3, 4. Right? So you can see here, it is coming till 6 hours. Action line is beginning at 4 hours and it is going up till 10 hours. Rest everything is the same, right? Rest everything is same. You have to mark you have to plot the BP, you have to plot the temperature, you have to plot how many contractions, you have to plot fetal heart rate. Rest everything is same. These are the only two differences between modified WHO partogram and composite partogram. Number one, in modified WHO partogram, active phase is beginning at 4 centimeters and the latent phase is absent, right? Now let's do the questions which have been asked on partograms, and believe me, there are number of questions which have been asked in partogram recently in AIIMS. So first question, from what centimeters of cervical dilatation is partogram plotted in regular intervals? So from what cervical dilatation in modified WHO partogram it is plotted at 4 centimeters. So your answer here is 4 centimeters. Partograph represents various stages of labor with respect to time. True about partograph is all except. So this is AIIMS November 2016 question. Each small square represents 1 hour. Is that true? No. Each small square represents 30 minutes. Let's see the other options also. Alert line and action lines are separated by a difference of 4 hours. Yes. Partograph recording should be started at a cervix dilatation of 4 centimeters. Yes, that is what WHO modified partogram says. Send the patient to the first referral unit if the labor progression line crosses the alert line. Yes. So the answer here is option A. Next question. A 38 weeks primigravida presented to the labor room with minimal labor pains and contractions. On examination, the cervix is 2 centimeters dilated and 50% effaced. That means she is in latent phase. Heart rate of the patient is 86 per minute. Blood pressure is 126 by 76 millimeters of mercury. What should be done next? Now, option A, induce labor by artificial rupture of membranes. Option B, give oxytocin to augment labor. Option C, sedate the patient. Option D, observe the patient and wait for increase in uterine contractions. Now see, the question is telling you that the patient is in latent phase and nothing else. The patient has just come to you, she is in latent phase. It is not a case of prolonged latent phase. Now if it is not a case of prolonged latent phase, obviously I am not going to sedate the patient, right? I would have sedated her if it would have been a case of prolonged latent phase, right? It is not a case of the protracted active phase. Just now patient is not in active phase. If it would have been a case of protracted active phase, then I would have done artificial rupture of membranes or then I would have given oxytocin. But this is simply a patient coming to you and at that time she is in latent phase. So I don't have to do anything. I just have to observe the patient and wait for increase in uterine contractions. Option A, option B and option C are ruled out. These two are done in case of protracted active phase. This is done in prolonged latent phase, right? So there is nothing like that. So I'm going to just observe the patient. Next question. Again, this is AIIMS November 2016. The following graph represents the stages of labor. Which of the following statements is true about graph C, right? So let's see graph C here. Before that, I want all of you to notice here that they have made a line from 3 centimeters, right? This means that in this graph, active phase is beginning at 3 centimeters. This is the line which they have already drawn and they have given you, right? Now, look at graph C. In graph C, the patient came and by approximately 9 to 10 hours, her latent phase is over because here the line is showing us that the active phase is beginning at 3 centimeters, right? So when the patient came by approximately 9 or 10 hours, her latent phase is over. So there is no problem in latent phase. Then the patient started dilating. She started dilating and she started dilating and she reached 6 centimeters. Now, when she reached 6 centimeters, approximately the time was 12 hours. Right? Now, this patient is continuously 6 centimeters dilated. The plateau is showing that she is continuously 6 centimeters dilated. And for how many hours is she 6 centimeters dilated? Roughly for 6 hours. Right? Roughly, this over here will be 18. So, roughly for 6 hours, your patient is 6 centimeters dilated. She is at the same dilatation and nothing else has been mentioned. So, we are taking it for granted that the contractions are adequate and the membranes are ruptured. So, what is your diagnosis? Your diagnosis is active phase arrest. Right? So, let's see the options. Secondary arrest after progression of labor. So, active phase arrest is also called as secondary arrest after progression of labor. Prolonged active phase? No. Prolonged latent phase? No. Normal labor? No. Right? Whenever you get a plateau in the active phase, always remember, plateau means that it is the same dilatation which is continuing, and that means active phase arrest. Clear? So, for a better understanding of all questions like this, let us have a look at the curves of labor. Now, whenever you get a graph, right, apart from seeing that the dilatation and the time in hours, what you have to see is any marking made there? And because that marking is going to tell you that when this graph was made or when that particular question is asked, what is the active phase which they are taking and what is the latent phase? For example, in these graphs here, they have told us that this is the latent phase, right? And it is coming up till 3 centimeters. And over here, this is the active phase, right? Now, if you look at graph A and graph B, in graph A and in graph B, in graph A, the latent phase is ending at 6 hours. That's very normal. And in graph B, the latent phase is ending at 8 hours. That's very normal. So, there is no problem in the latent phase in graph A and in graph B, right? Now, we know that in this graph, the active phase is being taken as 3 centimeters. And we know that the minimum rate of cervical dilatation is 1 centimeter per hour. So, from 3 centimeters to 10 centimeters, maximum it should take 7 hours, right? In graph A, the 10 centimeter dilatation is happening at 8 hours. So, from 6 hours to 8 hours, that means it is hardly taking 2 hours. And in 2 hours, the entire cervix is getting dilated, right? From 3 centimeters to 10 centimeters, it has just taken 2 hours. That means it's absolutely normal. The latent phase was normal and the active phase is normal, right? Now look at graph B. In graph B, from 3 centimeters to 10 centimeters, how much time it has taken? So, approximately from 8 or 9 hours to 12 or 13 hours, right? So, that is approximately 4 to 5 hours. Again, that's normal, right? So, that means active phase is normal in graph A also and in graph B also. Latent phase is normal in graph A also and in graph B also. So, graph A and graph B are representing graphs of normal labor. A is normal labor in a multiparous female and B is normal labor in a primigravida female, right? So, these are normal graphs. Clear? Now, look at graph C. So, I am erasing all this so that now you have a look only at graph C. In graph C, I can see a plateau at 6 centimeters, right? And this plateau is happening from 13 hours and it is happening up till 18 hours. That means 5 hours have passed and still the dilatation of the cervix is 6 centimeters, and that means it is active phase arrest. Whenever you get a plateau in active phase, that means it is active phase arrest. So what is graph C showing you? It is a graph of active phase arrest. And how do you manage that? All of you know. Caesarean section. Now have a look at graph D. So I'm erasing the graph C thing so that you concentrate only on graph D now. In graph D, the latent phase was ending at 12 hours. Okay, fine. That means the patient was 3 centimeters dilated at 12 hours. So from 3 centimeters to 10 centimeters, maximum it should have taken 7 hours more, right? So 12 plus 7, that is 19. So by 19 or 20 hours, it should have been fully dilated. But here the patient is fully dilated by 27 hours. So from 3 centimeters to 10 centimeters, 3 centimeters it was at 12 hours, right? And 10 centimeters it is at 27 hours, right? Which means it is taking 15 hours to cover 7 centimeters of dilatation. That means what is the case? It is a case of protracted active phase. There is no plateau, that means there is no active phase arrest. Here it is a case of protracted active phase. The active phase is happening slowly. It is not this that the dilatation is constant. Dilatation is happening, but dilatation is happening very slowly. So what is your graph D representing? It is representing protracted active phase. Clear? Now have a look at graph E. In graph E, the latent phase is taking 23 hours. 23 hours it is taking for the latent phase, right? Now, when you take latent phase ending at 5 centimeters and active phase beginning at 6 centimeters, at that time, like the recent times, the latent phase is said to be prolonged if it is more than 20 hours in a nulliparous female or if it is more than 14 hours in a multiparous female. And when you were taking latent phase to be ending at 3 centimeters, like it is happening in this graph, right? WHO said when latent phase ends at 3 centimeters, it is said to be prolonged if it goes more than 8 hours. And here it is taking 23 hours. Now, when it is taking 23 hours, that means it is a case of prolonged latent phase, whether we follow the earlier criteria or we follow the new criteria. So, this is a case of prolonged latent phase. Graph E is representing prolonged latent phase. Clear? Now come back to your question. In your question, you can see graph A. In graph A, latent phase is taking how much? Latent phase is going up till 20 hours, rather a little more than 20 hours, right? So this means graph A in this figure is representing prolonged latent phase. This graph A is showing prolonged latent phase. I hope all of you have understood how to interpret the graphs whenever they are given to you. Clear? Whenever you get a plateau in active phase, that is active phase arrest. Otherwise, you will have to see where is the active phase beginning and where is the active phase ending in order to diagnose protracted active phase, and similarly see where is the latent phase beginning and at what time it is ending to diagnose prolonged latent phase. Clear? Now, with this, let's come to the next question. The next question is saying, a 20-year-old primigravida is admitted with term pregnancy and labor pains. At 4 a.m., she goes into active stage of labor with 4 centimeters cervical dilatation. Membranes rupture during per-vaginal examination, showing that the liquor is clear. A repeat examination after 4 hours of good uterine contraction reveals that the cervical dilatation is only 5 centimeters. Contractions are good, and from 4 centimeters it has come only to 5 centimeters in 4 hours. What should be the next step in management? So first tell me, what is your diagnosis? My diagnosis here is a protracted active phase. That means active phase is going very, very slowly. I would have called it as an active phase arrest if instead of 5 centimeters here it was given 4 centimeters. That means the patient was in same dilatation for 4 hours. Then I would have called it as an active phase arrest. But because here the cervix is dilating from 4 centimeters, it has become 5 centimeters. That means I cannot call it as arrest. I am going to call it as protracted active phase. And whenever you get a patient with protracted active phase, I told you what is the next step? Next step is you have to rule out CPD or you have to rule out occipito-posterior position. So let's see the option D. Option D is reassess for occipito-posterior position and CPD. Once you have ruled these things out, then you are going to go for membrane rupture or for oxytocin. In this case, membranes are already ruptured and question is already saying that the contractions are good. Clear? So now coming to another very important topic which I have to discuss with you, and that is CTG tracings. But before I discuss with you CTG tracings, you should understand what are the characteristics of fetal heart rate. Right. Now, the first characteristic of fetal heart rate is, what is the actual fetal heart rate? Fetal heart rate, it is said to be normal if it is between 110 to 160 beats per minute. If it is less than 110, it is called as bradycardia. If it is more than equal to 160, it is called as tachycardia. Clear? That is one thing. Number two, a very important characteristic of fetal heart rate is that fetal heart rate, it is never fixed. If you take out a fetal heart rate monitoring strip, you will see that that is how the fetal heart rate is. It will increase, right? This is how the pattern you get. So that is called as fetal heart rate variability. Fetal heart rate, it keeps varying between 5 to 25 beats per minute. Which means that just now I will hear the fetal heart rate, it will be 116 per beat per minute, then it will be 118, then it will be 120, then again it will come to 118, it will come to 116. Within the normal range, it keeps on varying between 5 to 25 beats per minute. That is a very important characteristic of fetal heart rate, and that is fetal heart rate variability, right? If fetal heart rate variability decreases or if fetal heart rate variability is absent, both these are bad things to happen, right? So, if fetal heart rate variability decreases, that is something wrong to happen. Similarly, if fetal heart rate becomes fixed, that is also something wrong to happen, and that is called as sinusoidal heart rate pattern. Sinusoidal heart rate pattern. Now, sinusoidal heart rate pattern needs a little more explanation. So, what is sinusoidal heart rate pattern? When the fetal heart rate becomes fixed, that is called as sinusoidal heart rate pattern. Right? So you are going to get something like this on the CTG strip, or you can get a wave-like pattern, a sine wave-like pattern. Right? This is also figure A is also sinusoidal heart rate pattern, and figure B, when you get a wave, a sine wave-like pattern, that is also sinusoidal heart rate pattern. Sinusoidal heart rate pattern is a very ominous finding. Why? Because sinusoidal heart rate pattern indicates that there is fetal anemia. And you can get fetal anemia if there is twin-to-twin transfusion syndrome in the donor twin, right? In case of RH incompatibility, or in case of vasa previa. And whenever you get sinusoidal heart rate pattern on a CTG strip, then the management is immediate delivery. Immediate delivery. Clear? So, one characteristic of fetal heart rate was the fetal heart rate itself. The other thing is fetal heart rate variability. A third characteristic of fetal heart rate is fetal heart rate acceleration. Fetal heart rate acceleration. So let's talk about fetal heart rate acceleration. Whenever fetal movements occur, fetal heart rate increases, right? And how much it increases? It increases by 15 beats per minute for 15 seconds. This is called as fetal heart rate acceleration. Fetal heart rate acceleration always denotes that the fetus is healthy. Right? So that is fetal heart rate acceleration. This means that whenever you are getting fetal heart rate acceleration, it is something good to get, right? Rather, I want that there should be fetal heart rate accelerations on the CTG strip. Clear? Now, so you are in your labor room and a patient comes to you. She complains of decreased fetal movement. So first you have to tell me, the normal fetal movements are 10 movements in 2 hours of rest or 10 movements in 12 hours of activity. Right? So that is normal fetal movements. So whenever you have a pregnant female who comes to you and she says that I am having decreased fetal movements, please do not take it as a light problem. Decreased fetal movements, it is indicating that yes, there might be a fetal distress, right? So whenever a patient comes to you with decreased fetal movements, the next step, right? Now the first option and the second option. First option is modified biophysical score. If this is not given as an option in your questions, then the second answer which you are going to mark it as NST. So whenever a patient comes to you with decreased fetal movements, the first thing what you have to do is you have to do a modified biophysical score or you have to do an NST. Both these are screening tests. Right? What is modified biophysical score? Modified biophysical score is NST and you are checking the amniotic fluid index. Why I am saying the better answer is modified biophysical score? Because in modified biophysical score, not only are you checking the NST, not only are you doing the NST, and NST always indicates, it any acute problem which has happened with the fetus. So any acute problem which has happened with the fetus, that will be detected by NST. An amniotic fluid index will detect any chronic problem or any chronic injury which had happened with the fetus. That is why a better option is modified biophysical score. But most of the times this option is not given, right? In that case, you are going to mark it as NST, right? Now, how do you do an NST? So, see here. In an NST, whenever a patient is complaining of decreased fetal movement, you are going to relax her and you are going to make her lie down. And like there are the ECG leads, similarly, we have the fetal heart rate monitoring leads, and this you are going to tie it around, there will be a belt which you are going to tie it around her abdomen, right? And this you are going to do for 20 minutes. For 20 minutes, the machine, the NST machine is continuously going to record the fetal heart rate, right? So you are going to get continuously for 20 minutes, you will get a strip in which there will be fetal heart rate, like you get the ECG strips. During these 20 minutes, you are going to tell this female that whenever she will feel fetal movements, she is going to press a button, right? And that button, whenever she will press, it will appear in the form of an arrow on the strip. Do you see these arrows? So it will come in the form of an arrow. And what you have to look is that when fetal movement is happening, at that time is the fetal heart rate increasing or not, right? So when you are doing an NST, you are going to do NST for 20 minutes. Right? For those 20 minutes, you are going to tell the patient to lie calmly and to press the button whenever she feels fetal movements, right? In a period of 20 minutes, you should get 2 or more than 2 accelerations. If you are getting 2 or more than 2 accelerations, that means that is called as the NST is reactive. That means the fetus is normal and you will send the patient back home, right? But if you are getting less than 2 accelerations, in that case, you are going to repeat the NST for 20 more minutes, right? That means total how much? Total 40 minutes. Now, during those 40 minutes also, if you are getting less than 2 accelerations, then that means there can be a problem with the fetus, and in that case, you will have to go for the diagnostic test. And the diagnostic test is biophysical score. Clear to all of you? So I am repeating it again. Whenever you get a female who complains of decreased fetal movement, first you have to do a screening test. Screening test, the best answer is modified biophysical score, right? Or the second best answer is you do an NST. If NST comes out to be non-reactive, what do you mean by a non-reactive NST? A non-reactive NST means that you are getting less than 2 accelerations in 40 minutes, right? In that case, you will do the diagnostic test. And what is the diagnostic test? Biophysical score. Now, same thing, same procedure if you are doing at the time of labor. When the patient is having contractions, so that means now you are going to monitor the contractions also. Same thing, that is called as CTG, cardiotocography, right? When you are doing it during pregnancy, when the patient is not having labor pains or any contractions, that is NST. When you are doing it when the patient is having contractions, the same thing is called as CTG. So look here. In CTG, there are two monitors which you are keeping, right? One sensor is the contraction, which will sense the contraction, and the other sensor is for fetal heart rate. In case of NST, there is only one sensor for the fetal heart rate, right? Now, one very important thing which you have to understand is that at the time of contractions, what happens to the blood flow to the fetus? The blood flow to the fetus decreases. Again, that's a question, right? Why? Because pressure and volume are inversely related. When the pressure in the uterus will increase, the volume of blood which is going to the fetus will decrease, right? So if it is a normal fetus, it can tolerate this decrease and nothing will happen to its heart rate, right? But if this fetus is a compromised fetus, now in a compromised fetus, what happens is that because this fetus is already compromised, the fetal heart rate decreases by 15 beats per minute for 15 seconds. And this is called as fetal heart rate deceleration. Fetal heart rate deceleration is never normal, right? So fetal heart rate deceleration indicates that there is some or the other problem with the fetus, right? Fetal heart rate acceleration always denotes healthy fetus. Fetus heart rate deceleration denotes that there is some problem with the fetus, right? So when you are doing CTG, right, at that time you can get fetal heart rate decelerations. These fetal heart rate decelerations, they are of three types. Number one is early deceleration. Early deceleration. Now, if over here, this is the uterine contraction, right? In case of early deceleration, the dip in fetal heart rate, it will begin exactly at the same time as the uterine contraction begins. And the dip in fetal heart rate, it will get over once the uterine contractions are over, right? So the fetal heart rate begins to decrease at the onset of uterine contractions, and the fetal heart rate comes back to normal once the contractions are over. So this is uterine contraction. In other words, the dip in fetal heart rate will coincide with the uterine contractions. That is what is meant by early deceleration. Another very important point about early deceleration is that early deceleration, the decrease is gradual. It takes more than equal to 30 seconds, right? Early deceleration is seen in case of head compression of the fetus, right? Now, first let me show you early deceleration. So look here. I told you that in early deceleration, the decrease in fetal heart rate will coincide with the uterine contractions. So look here, this over here is one contraction, right? So the contraction begins. The moment the contraction begins, you can see that the fetal heart rate has dipped, and once the contractions are over, the dip is also over. The uterine contraction and the dip in fetal heart rate are coinciding with each other. This is called as early deceleration. See one more example here. The uterine contraction begins here. The fetal heart rate begins to decrease. The contraction is over, the dip is over, right? So this is a case of early deceleration. In early deceleration, the decrease in fetal heart rate will be gradual and it will be seen in case of head compression of the fetus. Now during labor, the head of the baby might get compressed, right? So early deceleration are physiological. If you are getting early decelerations, nothing much to worry, right? So this is the first type of deceleration, early deceleration. Then comes late deceleration. Now, as the name suggests, so if this is the uterine contraction, as the name suggests, in case of late deceleration, the dip in fetal heart rate will begin late. That means once the contraction begins, the dip will not begin. It will begin somewhere near the mid of the contraction. And when the contraction ends, the dip in fetal heart rate will not end. It will end late also. It begins late and it ends late. So let's see here. The dip in fetal heart rate will be like this, right? It is beginning later and it is ending later than the uterine contractions, right? Again, it is gradual. It is taking more than 30 seconds. Late deceleration is seen in uteroplacental insufficiency. And this is the worst type of deceleration to happen. It is the worst type of deceleration, right? It is the most ominous deceleration, right? So this over here was uterine contraction and this was the this was the fetal heart rate. Clear? Now let's look at a CTG graph showing this. See here. This is uterine contraction, right? Now when the uterine contraction began, is there any dip in fetal heart rate? No, right? The dip in fetal heart rate is happening after the beginning of the contraction, right? And the contraction is ending here. But do you see that the dip is still continuing? Right? So that means the dip in fetal heart rate is beginning later and it is ending later than the uterine contraction. Same case here. Here the contraction began here, but the fetal heart rate dip did not begin here. The contraction ended here, but the dip is still continuing. Everywhere you will see the same thing, right? So whenever you get a graph like this, where the dip in fetal heart rate is beginning and ending later than the beginning and the ending of uterine contractions, it is a graph of late deceleration. And late deceleration is the worst type of deceleration to happen. Clear? Then comes the third kind of deceleration, which is variable deceleration. As the name suggests, variable means that there will be no fixed relationship. No fixed relationship between the uterine contractions and fetal heart rate, right? Number one. Number two, there will be a sudden dip in fetal heart rate. It will take less than 30 seconds, right? And this type of deceleration is seen in cases of cord compression. Now, during labor, some cord compression is normal, right? That is why if you are getting variable deceleration for a very short period, that's normal. But if you are getting persistent variable deceleration, right, then that is a problem. Clear? So let's have a look at a CTG showing variable deceleration. This over here is the uterine contraction. This is the dip here, right? This is the dip here and this is the dip here. This is the uterine contraction. You can see that sometimes the dip is happening at the beginning of the contraction. Sometimes it is happening at the end of the contractions. And sometimes there is no relation at all to the contraction, right? So this is called as variable deceleration. Clear? Now, there are certain findings which are regarded as category 3 CTG findings. Category 3 CTG finding means the findings which are really bad and mean that you have to go for immediate delivery. What are they? Number 1, sinusoidal heart rate pattern. Number 2, bradycardia less than 100 beats per minute, right? If it is between 100 to 110 beats per minute, that comes in suspicious finding. That does not come in category 3 finding. Number 3, if you are getting late decelerations, right? Number 4, if you are getting persistent variable decelerations, right? So whenever you are getting sinusoidal heart rate pattern or if you are getting bradycardia less than 100 beats per minute, late decelerations or persistent variable decelerations, that indicates that the findings are ominous and you should go for immediate delivery, right? When you are doing fetal heart rate monitoring in the antenatal period, in that period also by chance if you get any of these findings, then also that it then means that you have to go for immediate delivery. And when you are doing during labor, that means you are doing a CTG. If you are getting these findings, again that indicates that you have to go for immediate delivery. Clear? Now one question. So this is an AIMS question. Which of the following fits into the criteria of severe variable deceleration? So variable deceleration, it can be classified as mild, moderate and severe. Right? Mild variable deceleration means if the fetal heart rate decreases but it remains more than equal to 80 beats per minute, irrespective of duration. So no matter for how long it has dipped, but the dip has been such that the fetal heart rate remains more than 80 beats per minute. Or if fetal heart rate decreases for less than 30 seconds, then irrespective of the depth. So no matter what the dip was, no matter how much the fetal heart rate went low, but it remained low only for less than equal to 30 seconds. Or if fetal heart rate is between 70 to 80 beats per minute for 30 to 60 seconds. Right? Moderate variable deceleration means fetal heart rate dips down to between 70 to 80 beats per minute for more than equal to 60 seconds. And severe variable deceleration means when fetal heart rate is less than 70 beats per minute for more than equal to 60 seconds. Clear? So this is how you define variable deceleration, the mild, moderate and severe. As you can see, severe variable deceleration means that fetal heart rate is becoming less than equal to 70 beats per minute and it will remain less than equal to 70 beats per minute for 60 seconds or more. Right? So now let's go back to the question. Which of the following fits into the criteria of severe variable deceleration? 70 beats per minute lasting for 60 seconds. Clear? So this is all what I have to tell you about partogram and CTG. And if you want to know more, you should watch my videos of OBS and Gynae with Marrow, which will be coming soon. And now let me answer all your queries related to partogram and CTG. Is that about the time when the active phase begins, at what dilatation the active phase begins. Now see, active phase, according to, there are various definitions. According to WHO, when the composite partogram was made, at that time the active phase began at 3 centimeters dilatation of the cervix. When modified WHO partogram was made, at that time the dilatation of the cervix at which the active phase began was 4 centimeters, right? And now, according to ACOG, the recent one is that active phase begins at 6 centimeters. So that depends on the question which is asked, what you are going to answer. Now it is 6 centimeters. Earlier, according to the composite partogram, it was 3 centimeters and then it was 4 centimeters when the modified partogram was made. And this was the reason why I was telling everything in detail when I started from telling you about normal and abnormal labor. That was one question which I saw which had come up in the comments, right? Number 2 question, somebody had asked that when there is a protracted active phase, in that case, what is the management? I have repeatedly told that the management of protracted active phase is you have to augment labor. But before that, what you have to do is you have to check whether there is no CPD and you have to rule out occipito-posterior positions. Then you have to give oxytocin and then you have to rupture the membranes to augment labor, right? Then another somebody had asked that when we say that oxytocin is given in case of active phase arrest, at that time, what is the time duration for taking it as active phase arrest? Normally, the time duration for active phase arrest is 4 hours. If the cervical dilatation remains constant for 4 hours in spite of good uterine contractions, then you call it as active phase arrest. Clear? But suppose the contractions are not good and you have started oxytocin. In that case, the total duration is 6 hours. It is not 4 hours plus 6 hours. The total duration is 6 hours and then you say that there is active phase arrest. Clear? Now, there was one question where you were getting a little confused and that was this question. Here, the question was saying that the patient has come to you at 5 centimeters dilatation. The cervix has remained unchanged 2 hours later. The contractions are 280 Montevideo units and after additional 2 hours of labor, still the patient is 5 centimeters dilated. That means 4 hours have passed and still it is the same dilatation. Right. Now, I told you that you are going to make a diagnosis of active phase arrest when the membranes are ruptured and when adequate uterine contractions are present. Right. Now, what you have to do is you have to see the options and then you have to answer. Here, if the option would have been rupture the membranes, I would have taken that as the answer. But because in the question, the options given are perform cesarean section, continue to wait, augment labor with pitocin, attempt delivery via vacuum extraction, perform an operative delivery with forceps. Now tell me, in this case, they haven't given us this option that you should rupture the membranes. So how can I answer that? Right? In that case, I am going to take it for granted that the membranes are ruptured and in that case, I am going to take it as the cesarean section. Perform cesarean section. You always have to answer a question based on the options given to you, right? this question, because there is no option like rupture the membranes, I am not going to say that I am going to rupture the membranes. In this case, I am going to take it for granted that the membranes are ruptured, right? Then, now, there was some confusion. Here, when I was explaining you these graphs, right, these were the curves of labor. Somebody was saying that why can't graph A be taken as a graph of precipitate labor, right? Now, what is the definition of a precipitate labor? Precipitate labor is when the combined duration of first and the second stage of labor is less than or equal to 3 hours. Here, the duration of labor, what it is coming? It is coming to be roughly 10 hours, right? So, you cannot call it as a precipitate labor, right? Then, see, we were talking about sinusoidal heart rate pattern. Now, I was telling you that in sinusoidal heart rate pattern, fetal heart rate is fixed, right? Or you get a wave-like pattern. This is a pattern which you get in sinusoidal heart rate. If you get a CTG strip where you get a pattern, a wave-like pattern, then you are going to call it sinusoidal heart rate pattern, and this is an omnious finding. See, all CTG strips are very, very important for your image-based questions. They are really very, very important questions, and that is why I have taken a lot of time to explain you that, right? Now, this is my request to all of you. See, as a student, as an individual, what we always want more, right? We always want more marks than our friends. We always want everything more in life, right? And when you are wanting everything more in life, you will have to give more, right? So if you want to get more, you will always have to give more. That is the fundamental. So when I say you will have to give more, you will have to give more of your time. You will have to give more hard work. You will have to give more of your sweat. You will have to devote more time. You will have to learn more and you will have to know more. Then only you are going to get more marks and you are going to get a better rank. And if you are willing to know more, if you are willing to learn more, this is the place where you have to be marrow. And this is the Obs and Gynae video which you should be watching, because I don't teach Obs and Gynae in shortcut, right? I will start from the basic and I will take you to the advanced. If you feel you already know a lot of Obs and Gynae, then don't come to this platform, right? But if you feel that you want to know more about Obs and Gynae, because see, Obs and Gynae is a very, very scoring subject. If you understand it once, you can answer at least out of 30 questions. I can, guarantee that you can answer 27 to 28 questions. But that is if you are ready to give more time, if you are ready to learn more. If you are here for shortcuts, success doesn't have any shortcuts, right? To know more and to get more, you should enroll to Marrow and you should enroll to my Obs and Gynae video. Now, I think I have answered most of your questions. Right. Okay, so somebody is asking me indications of NST and from when should we start NST. NST monitoring should be done in all patients. In all pregnant females, you have to do an NST, irrespective of the fact whether she is a high-risk pregnant female or whether she has low risk, right? NST is started from 32 weeks of pregnancy. That is the time when you should start doing NST, and you should do NST every weekly. Because if you are getting a reactive NST, that indicates that at least for 1 week the fetus is out of danger, right? So every week you have to repeat NST. But if the patient is a high-risk pregnancy patient, for example, if she is a PIH patient, for example, if she is a post-term patient, for example, if she is a diabetic patient, in that case you have to repeat NST twice weekly. Now, if she is a patient whose diabetes is uncontrolled, right? Uncontrolled diabetic patients, they have very high risk of intrauterine death. In that case, you have to repeat NST daily, right? So that is how and when you have to do NST. As such, there is no duration of active phase according to ACOG. ACOG says that the dilatation should be, minimum dilatation in a nulliparous female should be 1.2 centimeters per hour, and in a multiparous female it should be 1.5 centimeters per hour. So as such, they are not telling you that if it is more than this then it will be prolonged, or if it is less than this then it will be prolonged regarding the active phase. Okay, biophysical score. See, modified biophysical score, as I told you, it is a screening test. In modified biophysical score, you are seeing only two things. Number one, NST, and number two, you are seeing amniotic fluid index. But as far as a biophysical score is concerned, biophysical score is a confirmatory test or a diagnostic test, right? In biophysical score, you look at 5 variables, and these 5 variables you can remember by a mnemonic: TB, meningitis, always notorious. T stands for fetal tone, B stands for fetal breathing movements, M stands for gross body movements, A stands for the depth of a single largest vertical pocket. Now I want you to be very careful here. In modified biophysical score, it was amniotic fluid index which you were looking at. In biophysical score, it's the depth of a single largest vertical pocket which you will look at. And N stands for NST. So in biophysical score, there are total 5 things or 5 parameters at which you will look at. In modified biophysical score, there are only 2 parameters, right? In case of biophysical score, to each parameter, you give a score of 0 or you give a score of 2. So it's an all or none law. So the maximum score which can go in a biophysical score is 10, right? I am again repeating. Active phase according to WHO begins at 4 centimeters. According to ACOG, it begins at 6 centimeters, right? Okay, if nothing specific is mentioned, right, for see, like this, a question is not going to come because there are various parameters. So they will tell you whether they are asking as per WHO guidelines or as per ACOG guidelines. If nothing is mentioned, that means they are talking about recent. And recently now it has started being taken as 6 centimeters. The active phase begins at 6 centimeters as per the recent guidelines. In India, we follow the modified WHO partogram. That is what we follow in India. Yes, Manning score and biophysical score, they are the same thing, right? So whether you say biophysical score or whether you say Manning score, it's one and the same thing. Okay. Now, I am the wrong person to ask what are the high yield topics, because as I told you, I don't believe in shortcuts. I believe that you should remember more. See, obs and gynae, you have to remember most of the obs and gynae. But if you ask me high yield topics, I will say yes, partograms, CTGs, Dopplers, all these are very high yield topics. Then physiological changes in pregnancy, that's really very, very important. Then diabetes in pregnancy, all the recent criterias which have come regarding diabetes, that's very important. Malpresentations, that's also another very high yield topic on which you have to get 1 or 2 questions, right? Early decelerations, yes, most of the times early deceleration is physiological, because early deceleration means head compression, and head compression can occur normally during labor. But if you are getting persistent, by persistent I mean for a very long time, if you are getting early deceleration, then that is a problem. But then again, it is not taken in category 3 findings. Category 3 CTG findings, we are taking it as late deceleration, that's a problem, and persistent variable deceleration, that's a problem. Right. Okay. Latent phase according to ACOG. If you have heard the lecture properly, I have discussed that. According to ACOG, latent phase is said to be prolonged if it is more than 20 hours in a nulliparous female or more than 14 hours in a multiparous female. According to WHO, latent phase is said to be prolonged if it is more than 8 hours, right? But according to the recent guidelines, it's 20 hours and 14 hours. See, this video is, or this topic which I'm teaching is partograms, and I'm teaching CTG, right? For Dopplers, you should have a look at the videos which will be uploaded soon in Marrow. All my videos, all obs and gynae, the entire obs and gynae will be available with Marrow. So if you want to know more about Dopplers, you should have a look at the videos which will be available with Marrow sooner or later. How soon? Don't ask me that. So many questions I'm getting regarding Dopplers. Okay. I said decelerations indicate that there is some problem with the fetus, right? So deceleration, if there is early deceleration, again there is a problem. The head of the baby is getting compressed, but head of the baby can get compressed during labor. That is why I said it is physiological, right? The mnemonic for biophysical score which I told was TB meningitis, always notorious. T stands for fetal tone, B stands for fetal breathing movements, TB meningitis. M stands for gross body movements of the fetus. A stands for amniotic fluid. Now, when you are doing amniotic fluid, you will look at the depth of the single largest vertical pocket, right? And N stands for NST. I really don't know which graph C you are talking about. Yes, old partogram, the WHO said active phase begins at 3 centimeters dilatation. Modified partogram, it is saying 4 centimeters. Twin pregnancy is a high-risk pregnancy, so you are going to repeat NST twice weekly. Right? I think I have answered most of the questions here, right? All the best for your exams. Keep revising and practicing.